psychosocial support for refugees in urban settings. And I see I have a problem in moving on to the next slide, which is what you always see. Probably this is what I need to do, yes. So before we start, I would like to present the people who are behind this webinar. We are with 5 people. First of all, Attila Szabo, who is in the background, working from Budapest to assist us all. Tilde Norregaard, who is with the public health section, and myself below on the right. We have 2 excellent presenters, and I thought it would be nice to see their face as well instead of only their PowerPoints. We have Nancy Barron, Director of PSTIC in Cairo, and we have Zainab Hijazi, presenting from Los Angeles, and she's the Global Mental Health Officer of IMC. Now, before we start with the content, a few practical issues. I want you all to know that this session will be recorded and maybe disseminated on our website. So be careful what you say. Secondly, all participants are now muted when they enter the discussion, because otherwise we would have too much noise. But in the question and answer sessions, you will be able to ask questions and we will unmute you. We will explain you later. Thirdly, we would like to encourage you to share your experiences through Twitter. So you can tweet your responses or your ideas using the hashtags Urban Refugees and MHPSS. If you use both of them, we will be able to trace your tweets. Now, the session was planned for 1 hour, and the presentations will be finalized within that time. But we may continue a little bit longer to give you opportunities to ask questions and to share things. So we may go on a little bit longer. Who wants to continue is welcome. Now, a few words to set the scene. This webinar is organized by the Urban Refugee Task Force. That is a network of the UNHCR and various other organizations with the explicit objective to strengthen collaboration and engagement in urban areas around refugee work. Is actually something that UNHCR has put as a high priority. If you want to know more, please go to our website, www.urbangoodpractices.org, with lots of information on it. Urban refugees get more and more important. I think most of you know about that. I looked up some figures in the Global Trends report that was released last week. And unexpectedly, we see that the share of urban refugees within the total population of refugees is increasing again. We are now at around 56.1% of urban refugees. Last year it was 53%. And I'm now mainly talking about the refugees under UNHCR's mandate. We still have millions of Palestinians under UNRWA as well, who are mostly urban as well. Now, secondly, I would like to say something about MHPSS, because some of you may be familiar with the Urban Task Force, but not so much with MHPSS. MHPSS is a kind of awkward acronym. It stands for Mental Health and Psychosocial Support. It's important to emphasize this because with the word MHPSS, we indicate that it is a broad, holistic concept that covers actions based on improving well-being, as well as actions to target mental disorders, to prevent them and to treat them. So it's a concept that is relevant for many fields, including health, including education, and including community work. When I talk about MHPSS problems, it's therefore important to realize that it goes from psychosocial problems related to poverty, to gender-based violence, etc., through mild and moderate mental disorders such as depression and PTSD, up to severe mental disorders. And sometimes the programs for MHPSS also cover more neuropsychiatric disorders such as dementia or epilepsy. The numbers of people with MHPSS problems is high. Worldwide, about 2 to 3% have severe mental disorders, around 10% mild or moderate mental disorder. And as you can see in this figure, the numbers go up after an emergency, including the more severe disorders that go up with 50%, as well as the moderate disorders that almost double. Needless to say is that in a refugee setting, very many people have psychosocial distress, perhaps most of the refugees. Now, this is a figure that shows an estimation of how the psychosocial distress and psychosocial problems develop. In an acute phase, it's very high. Then when things start to settle, services are being established, social fabric is getting restored, we see that the distress is going down. But what we see that in protracted emergencies, of which we have a lot these days, we see that slowly the distress goes up when people realize that they have very limited livelihood options and options for a future. Now this slide I will do very, very quickly. What we can see is that in many MHPSS programs for refugees, in the past we made wrong assumptions. Assumptions that everybody is traumatized, everybody needs counseling, and we focused a lot on traumatic events in the past, while actually to some extent ignoring the current life stressors. Lastly, we used a model that was based on service delivery only, while we were actually forgetting to work with refugees themselves. Within UNHCR, we say that MHPSS is something for all humanitarian workers. And in this way, we divide our work in two concepts: MHPSS approach, which is something that is relevant for all aid workers, and MHPSS interventions that have a primary goal to improve mental health and psychosocial well-being. I think today we will talk a lot about MHPSS interventions, but we should not forget that the approach is a key element of any humanitarian response as well. Within MHPSS, we use a public health framework based on various layers of support. You can see that here. The first layer is here, the layer in the bottom. That is what we used to call within UNHCR an MHPSS approach, which is including social considerations in any services that you do for or with refugees. Then we have layer 2, which is focused on strengthening community and family support. So basically, helping communities and families do what they're supposed to do, providing support, providing aid to each other. In refugee settings, this social fabric, these mutual chains of support are often affected. And the actions that we need to take is to help people to do this again. The third layer is the layer of focused person-to-person support, but delivered by non-specialists, by trained lay workers. That could be refugees, but it could also be other humanitarian professionals. And lastly, we have clinical services provided by psychologists, psychiatrists, or psychiatric nurses. We have to remove the cell phones from our office.
Yeah, I have done.
Okay. There are two key documents that I would like to refer you to. One is the UNHCR Urban Policy that you see on the left, and on the right, the operational guidance for mental health and psychosocial support in refugee settings. Those documents, to some extent, overlap, but they could overlap more. In the urban policy, there is little about mental health, and in the mental health guidance, there is little about urban settings. So what I hope to reach with this webinar is that the two documents become more close to each other when we are making next versions. Now, I'm now ending my, my introduction. This is a typical camp setting in Cameroon here. If you want to do a mental health and psychosocial program, it's relatively easy. Finding refugees is not so difficult. You go to the food distribution and you'll find them. Refugees themselves know where to go. They know where the clinic is. They know where the services are. Working with communities is also relatively easy. You can make a group easily. You can sit under a tree or in the grass and you can do your work. But how is that in Kuala Lumpur? How is it in Nairobi? So the challenges in these situations are, where are the refugees? How can we find them? And how can they find us? And I visited the two places that I just showed, Kuala Lumpur and Nairobi, and I found major challenges. And although the contexts of Africa and Asia are very different, the issues were the same. Refugees have difficulties in reaching the services provided by NGOs because transport is difficult. Refugees have to work during the day, and they can't go to services that are provided usually in office hours. And they have fear to be arrested or to be harassed. So these are major challenges, and there is little written about how to deal with these challenges. There are a few examples from programs mainly in the Middle East, as you can see here, but I hope to learn more about these challenges by the two presenters. The first one is Nancy Barron, Director of PSTIC in Cairo. She will introduce herself. And the second presenter is Zainab Hijazi from IMC. I would like to hand over the floor to Nancy now. Attila, can you do that?
Yes, Nancy, you're unmuted, and I'm handing over the presenter's rights to you. Please go ahead.
Thank you very much. Let me open up my PowerPoint. Give me 1 second. Let's see if we have it. It's a pleasure to see so many familiar names on this list. Lots of people, lots of countries, and lots of people I've known over the years. So thank you for being here. My presentation seems to be uploading, so that's good news. I'm talking to you from Cairo, Egypt. And I always, when I do these things, feel like I'm talking to myself. It would be really nice if someone could say something. Many of you know me, and that I have been doing mental health and psychosocial support in emergency situations for the past 25 years. That 10 of those years were spent in Asia, 10 in Africa, and now the last 5 have been spent in the Middle East. Attila, it seems to be taking a long time to upload. Can you see what's happening here?
No, Nancy, not yet. I guess a little more time for your presentation to appear.
Okay, I think it only took a minute yesterday. Should I try again?
Yeah, why not?
Okay. Everyone has to be patient when you're talking halfway across the world. Let's see what happens if I do it a second time. I'm opening it again. It seems to have nice lines downloading, but it doesn't seem to be coming up. Let's see. I can see all these lovely gray lines moving back and forth, but I don't see anything coming up.
Nancy, if something is wrong on your side, I can give the presenter's rights back to Peter, who can upload the presentation and help you in moving forward with the slides, if that's okay for you.
Yeah, I think you're going to have. I don't see it moving anywhere. It seems to just be gray lines.
Okay, so let's do this way. Peter, I'm giving the presenter's rights back to you, so please upload Nancy's presentation.
Okay, Nancy, can you see your own presentation now?
I cannot. We couldn't see yours the whole time either, Peter.
Okay.
We see it.
You can see it?
Yes.
Okay, great. You tell me when you want the next slide.
That's going to be difficult since I changed it on my end. It's just, you have any idea why it's not opening?
I'm not sure, Nancy, so maybe we need to go this way.
All right, then we're going to have to be patient because I think I have a few extra slides than what you're going to see. All right, so I worked on it after I presented it. So you should see in front of you two lovely photos. One is Egypt, the pyramids, and one is Egypt, the conflict. All right, maybe Peter, you could change the slide.
Yes, I did.
All right, and then again. So what am I here to do today? So today I'm here to, now I'm up. Now I can see it. I think it just took a long time on this end. Okay, so Peter, I can move it myself now. Okay?
Okay.
All right, I've got it. So, thank you. The goals of today. So I was asked to describe the mental health and psychosocial program in Egypt and how it responds to the problems in the urban context. I'm here to cherish on some of the challenges we have in our urban context, and hopefully that we'll find that working in similar situations in big countries around the world have some common ground. I'm here specifically to talk about the organization that I started in Egypt, which is the Psychosocial Services and Training Institute in Cairo. Okay. I guess the big question is, well, why share PSTIC from Egypt? Well, sometimes we say here in Egypt, if you can do it here, you can do it anywhere. But they might say the same thing in Kuala Lumpur and Nairobi. But I think it's a good example of the possibilities of intervention in the urban context, particularly because of the complications of its context. The first thing we always do, when we're going to start mental health and psychosocial support is to do an assessment. And an assessment in the urban context is always a bit more complicated than it is anywhere else. The first challenge is, how do we determine what are the problems? What are the needs? What are the resources? How do we actually find the gaps in a massive urban context when everything seems to be a gap? As Peter mentioned earlier, how do we access the people? And how in the end are we sure that the interventions we're actually doing meet the priorities of the people of concern? Our next challenge is really the outside influences that we can't control in the country, in the neighborhoods, the social, political, economic context, and how it really influences and directs our intervention. And the next challenge, well, it keeps changing. If you watch the news about Egypt, boy, we keep changing every single day. All right, so there's the need for ongoing assessment. We need flexible intervention to meet the continually changing needs and priorities. The Egyptian urban context, well, we have a population of 80 million people. 12 million of them live in Greater Cairo. Now, it's a drop in the bucket when we talk about refugees. There are about 200,000 refugees and asylum seekers. 50,000 are Africans, 10,000 or so are Iraqis, And recently, like Lebanon and Jordan and some of our neighbors, we've had an influx of Syrians. We now have about 136,000 registered Syrian refugees. And then there's the migrants and the closed files, which people say could be as many as 2 million people. Now, the urban context, as I said, directs the life of the refugees. Right? In Egypt, we have many different issues that are important to how it directs life. First has to do with the host government. I mean, what kind of cooperation do we have with the host government? Well, here, we have lots of problems. We have problems with UNHCR being able to have access to people who are detained. We have people who enter this country who want to be refugees, who should be refugees, who are detained and arrested for illegal entry. We have a problem with uncontrolled trafficking. And we have a registration problem. NGOs can't register here. We've got problems with the reservations that have been made for the Refugee Convention. We have problems in schools where Egyptian kids there were not enough seats for 250,000 Egyptian kids, let alone the refugees. The health system is inadequate. I can't even begin to talk about the health system. We'll just call it inadequate. We have protection issues. There are problems for Egyptians, and they're the same problem for the refugees. The problems are due to political instability, discrimination, sexual harassment, rising crime, lack of protection by the authorities. And then the whole idea that UNHCR has a limited ability to actually be able to protect. UNHCR also has limited capacities in the urban context here. UNHCR's budget was cut back $2.5 million last year for African refugees. The Syrian budget worldwide is 6%. There's minimal financial support. And here there's an inequity between what's available for Syrians and what's available for Africans and Iraqis. The refugees here live with the poorest of the poor. Accessibility to them is difficult. How do you find vulnerable refugees here? And for them to services, how in the world can they find the services in a city this big? When I first came to Cairo, now 6 years ago, full-time, I was here before that. But when I first came to Cairo, one of the things that was most obvious to me was that refugees were not doing work in NGOs or in the UN or anywhere. It's very different than the work I had done for so many years in camps, where refugee community leaders were also workers in many places. Well, we didn't have that here. So in 2009, I decided to begin PSTIC. I began with a basic principle that is about the value of refugees, assisting refugees in their own language and in accordance with their own culture and traditions. I was working from the premise that partnerships with communities and NGOs are essential, and the idea that we needed to integrate psychosocial support into services. That I wasn't here to start just a parallel service, but to integrate us into all the services that were around. There should be a psychosocial worker in the schools, in the legal services, in the healthcare. We work in compliance with the IASC guidelines, and PSTIC is affiliated to Securitism, and we're an implementing partner with UNHCR since 2011. What kind of issues do PSTIC workers assist? Well, most anything and anyone at any time. We deal with all ages of people, individuals, and families. We deal with people who have problems with their basic needs. They're newly arrived, they're unregistered, they're unprotected. As I said, the poor, people with security issues, people who are sick. We deal with psychosocial issues, people without hope, with little opportunity, women struggling, survivors of SGBT, single mothers, survivors of violence both here and at home, alcohol abuse, people who've been trafficked, people who've been rejected by their communities, people with disabilities, people with neighborhood problems, and perpetrators, refugee situations in all contexts, but particularly in the urban context, are victims, survivors, and some perpetrators. And we deal with mental health issues, severe mental illness, the despair, the lack of motivation, and sometimes suicide threats. Our list can go on and on. Our list of activities also go on and on, but most importantly, what PSTIC established was a network of community-based refugee psychosocial workers. And what we do is we train, we supervise, we support, and we network to provide community-based psychosocial and mental health support. Workers are selected by communities and integrated into their community, and integrated into the community services, the community associations, refugee schools, recreation programs, legal programs, all throughout. District psychosocial workers are a well-trained batch. Their training begins with 5 weeks of full-time training, and it continues 1 day a week forever. In the first year, they have 350 hours of classroom and field training. They're supervised as part of a team, so we have mixed country teams, Somalis and Syrians and Sudanese, all working together. And the teams meet every week for case support, just to support each other for case planning and for problem solving. And then each psychosocial worker has individual supervision twice a month with a psychiatrist who helps in particular with their mental health cases. We're part of a very active team that's working towards team building. Every week there's a meeting, every week there's a class, every week the team leaders meet, the supervisors meet. There's a continual effort for everyone to unite as a team with one mission, with one goal. As a training institute, we do training in communities, we do training for other NGOs, but we also do professional training with our own doctors and with people who are working with us that are clinicians. PSTIC works with the pyramid of intervention that Peter showed us earlier, that we basically work on all the layers in cooperation with the communities, the UN, the NGO partners, and even with the host government. If you look at the pyramid, you can see in red the PSTIC activities. I'm going to describe them in detail in a minute. But you can see that we have activities at layer 4, layer 3, layer 2, and layer 1. I think for me as a professional, having worked in many other countries, the big surprise was how much intervention was really needed at layer 1. But first what I'll do is talk about layer 4, because that's the most common, and that's the one that people expect people like us to do. The PSTIC does have a mental health support program. I think what's different for PSTIC than maybe other organizations is that we're a 24/7 service. That 24 hours a day, 7 days a week, our phones are on, and we're available for emergency response for urgent mental health cases. We do lots of things, from community-based awareness raising to identification and assessment of people with mental illness, moving in and out of houses, finding people who are really the most disturbed. We do case management, and we have a partnership with all the mental health clinics that are available to refugees here, as well as with psychiatric hospitals, private psychiatric, and the public hospital, as well as with the Ministry of Health Mental Health Secretariat. We make referrals to outpatient and inpatient services, and we run 2 clinics of our own, where we are providing specialized medical as well as counseling treatment. Our work is home visits, where we go back and forth making sure that people who are getting mental health care are actually complying. And we help people to get to the doctor when getting to the doctor is rough. Right? We support families, people who are mentally ill, and weekly we have a special support and socialization for people who've been hospitalized. We have psychosocial support. Lots of different organizations do that. I think what PSTIC is different, again, is with a 24/7 emergency response. The phones ring day and night. We work towards identifying people with problems, and because our workers are all community-based, it allows us to be able to be available to the most vulnerable. We do home-based assessments, counseling, psychosocial support. In the midst of an emergency, we would do psychological first aid, and on with case management. So we do referral, accompaniment, and advocacy for services because so many of these people can't manage to access on their own. We help people to access their community support system, and we do lots of activities in sport and art, and we have a theater group that you'll see at the very end. I will give you a link to a theater group that educates Egyptians about refugee issues. Now, we also have a counseling program. As we also expect by organizations like us at Layer 3. We do individual counseling in our clinics. Our psychosocial workers do it in the homes. We run support groups for STDs, for minors, for men, single mothers. We run support groups run by psychosocial workers, where it's in someone's home with a coffee ceremony, with lunch, a walk to the park. We run anxiety and stress management groups done by psychosocial workers. Sleep management groups done by psychosocial workers, that parent awareness workshops, as well as family counseling. Now, The urban challenge, though, has led us to other kinds of situations, and I'm presenting kind of a case example here, where we might have recently a minor child who was sexually abused in her neighborhood. The family goes to the police, and the abuser realizes the family went to the police. The abuser makes their way to the police. They make their way to the family. They threaten the family. The police back off, and the landlord tells the family to get out. I mean, what does a mental health and psychosocial support program do in that situation? I mean, are we enough to have that child and that mother come to our mental health clinic? Is it enough to provide psychosocial support? And experience has taught PSTIC that, in fact, it's not enough. And as you can see, that we are active in protection, that we would help to move this girl and her family into our transitional apartment. We would help them to find housing permanently in a new location. We would help refer her to STDD care and accompany her to treatment. We provide psychosocial support to the family, mental health care if it was needed, and then awareness to the community if the community somehow became involved. So layer one has become very important to PSTIC. That layer one, that advocacy for basic needs, has become very important because we believe that much of the emotional distress of refugees and asylum seekers is due to the hassles and distress experienced because of their basic needs. All right, so that's why we do this more and more. I'm an active member, as are my team, of UN and NGO Forum. We're an advocacy voice for refugees. That we're very active in case advocacy for the individual and family cases. We accompany people when it's not possible to other services. And because of all that, what we found over the years is we needed housing support. I've never done housing support before in a psychosocial program, but it's one of those places where our clients look at us and say, thank you, that's exactly what I need to help me feel better. Right? It's a 24-hour, 7-day-a-week service. We offer psychosocial support for people who are vulnerable and homeless or facing eviction or needing protection after having serious neighborhood or family or community problems. It's helping people to have a home, helping the homeless, helping a refugee, helping the displaced, making sure that they have a home base. We do advocacy in the community to make sure that if someone is homeless, that the community is the first choice. The community would help them first. If the community is not available, if the community is not safe, then we have a transitional apartment. We help people to identify affordable apartments. We help people to finance that needed security deposit so that they can move. Nobody has a bank account here. So they need a security deposit to move. They need help to do that when they have a protection issue. Sometimes we help single people to make new roommates, and sometimes we just help the poor to financially plan for how they can afford to live. As the years have progressed here, we also realized that due to the health problems, that on and on, over and over, we have major health problems. For many years, our psychosocial workers were the first-time responders. As an example, a case, it's 1 o'clock in the morning, the person's HIV positive, she's sick, she's got a fever, she's vomiting. And here in Cairo, the ambulance doesn't arrive. 4 hours later, we have her in a taxi, and she's unconscious. And we move from hospital to hospital to hospital, where they're saying, no HIV patients, no ICU, we don't want dying people. It's an Egyptian problem, it's a refugee problem. The big question is, what do? Do you accept it as an Egyptian and a refugee problem? Or do you try to find ways to make sure that the rights of refugees allow for people to get this kind of care? So we started a health advocacy program. We have now a health professional team. When Syrian doctors, Sudanese doctors, Mali nurses come here, they can't work. They can't work professionally because they're not licensed here, but they can be a health professional team. And that health professional team works alongside our psychosocial workers. About 1/3 of our emergencies are healthcare, and that we provide 24/7 emergency support to help people to access healthcare. We're the advocates. We take them by the hand and we help to make sure it happens. We mobilize the communities to make sure that they're there working with us to help the sick. Right, we accompany them into medical treatment afterwards, to specialists and support to make sure that they get the health care that they require. Over the years, we also became involved with the livelihood program. The poor of the poor, we managed to find people who are the most vulnerable and we're part of a project where we help to refer them to livelihood opportunities. Our PSTIC team, 44 psychosocial workers, 5 housing advocates, 7 health advocates. They're all from Eritrea, Ethiopia, Iraq, Somalia, Sudan, South Sudan, and Syria. We have 8 Egyptian psychiatrists. We have a small counseling team and many, many volunteers working in recreation and our theater team. In April alone, we serviced just under 1,200 cases, which is about 4,000 beneficiaries, about half African and Iraqi and half Syrian. In mental health care, we had 19 people in hospitals, 65 in outpatient, housing cases, groups. We ended up with about 300 new cases just in April, at least the same in May, probably more than that in June. It's a busy place, lots of turnover, and crises, somewhere between 30 and 40 crises a month. Crisis meaning psychosocial worker drops everything else they're doing and needs to respond. What are our lessons learned? My last slide, I think it's just 20 minutes. All right, it's the team, most important lesson. A team that's dedicated, committed, with strong ethics, that believes in the capacity for self-help. What goes with that team? Ongoing training, supervision, team building. Basically around here, there's hard work when we manage our stress and our burnout through the team support and trying and really believing that we feel satisfied because we do try. We persevere in a very hard time. Our model is about what can we do. We don't talk about what we can't do. We talk about what we can do. And importantly, to work in partnership, have respect and cooperation between us and communities, UNHCR, and NGOs. If you have time, you can, I'm sure this is going to be online, so you can follow that link and you'll see us. You'll see us dancing a bit, and you'll see our theater group. And as last, just to say that in September, I'll be teaching a course on the psychosocial consequences of migration and asylum. It'll be done, and you can see the site in front of you. You're certainly very welcome. I thank you very much. I've talked to myself for 20 whole minutes. I look forward to hearing you all and listening to questions and trying to answer what you have to ask. Thanks so much.
Thanks, Nancy, for the extensive presentation. Peter, you want to conclude, or we can go to the second presentation?
We can go to the second presentation. I think, Zainab, if you are ready, please come in.
I'm ready.
Zainab, you can start, please.
Great, thank you. So hello, everyone. I'm going to attempt to upload my presentation. All right. So I wanted to say hello and good morning from sunny LA. I'm very pleased to be part of this webinar today and to be given the opportunity to talk to you about IMC's approach to mental health and psychosocial support in urban settings. And while my presentation uploads, I just wanted to quickly introduce myself. So my name is Zainab, and I am the Global Mental Health and Psychosocial Officer working with IMC. I've been working with IMC for over 8 years now, and I am currently focused on the Middle East and North Africa region. Please bear with me while my presentation uploads. Mm. Peter, I don't mind you opening it from your end, and if you don't mind. Sorry about that, everyone.
Peter, can you try it from your end? Let's see if it works.
Yes, well, I'm going to do it now. 1 second.
Test runs always run perfectly, and then
David? Apologies to all of you. This happens sometimes. If you try to do a presentation with 3 continents in one virtual room. Anyway, if I would presenters right now, I will upload the presentation of Zainab.
Right, and as Peter begins to upload, I just really wanted to quickly describe the objectives of my presentation. And it will be one to describe, the challenges of MHPSS in urban settings, and I know that Nancy and Peter have both touched on this extensively. And I will kind of get into it a little briefly just to kind of pave the way towards IMC's approach to MHPSS in urban settings, and of course describe IMC's mental health case management model in responding to the multiple and complex needs of urban refugees. And I will also present some country examples from the Middle East. Great.
Okay, now it seems it works. Zainab, can you see your own presentation now?
Yes, I can see it.
If you need the next slide, tell me, and I will do it.
All right. Yes, please, next slide. And next as well, I just went through this. All right, so the Middle East is primarily urbanized and has long been a key destination for refugees. Currently, as Nancy mentioned, Syrian refugee groups constitute the most vulnerable urban populations in Jordan, Lebanon, Turkey, and Iraq. And though they face a range of health and protection needs, reaching and assisting them, especially for those who are not registered with UNHCR, can be very challenging. Because, difficulties persist in registering urban refugees because families are very dispersed within the host community, situated in various cities, and they're often very difficult to identify for service provisions and assistance, especially related to MHPSS. Now, urban refugees, they lack natural social support networks. They suffer from isolation within the host population. They face challenging in accessing various services and supports, and are more vulnerable to acts of violence and exploitation. In large cities, refugees, many of whom have experienced loss and been exposed to distressing events, are difficult to identify and reach with humanitarian services, including the basic services, health, mental health, and psychosocial care. So the lessons that we've learned in the process of providing humanitarian services to urban refugee populations have spawned a number of important issues in addressing their needs in general, including MHPSS needs. So what are the issues? Challenges facing the refugee community in the access, availability, acceptability, and quality of services and support. This is the AAAQ, which most of you are probably familiar with. The specific multiple needs of urban refugees, the limited local capacity to respond to needs, and accordingly capacity building at different levels from the refugee community itself to provide the services directly is very key. And of course, the needs of the host community. This is very, very often forgotten. Refugees often reside in the poorest areas and among vulnerable host families whose needs are often far from met. Host countries often have very weak or limited infrastructure to deal with the needs of their own citizens, let alone refugees. Next slide, please. So IMC's approach to MHPSS is consistent with global guidelines. And while many of the traditionally accepted guidelines for best practices and minimum standards for assisting refugees in emergency response conditions have only limited relevance to urban settings. But we have found guidance and best practices within the ISC MHPSS guidelines easily applicable and adapted to urban refugee settings. And this is something that Nancy touched on layer by layer. So IMC's approach includes, increasing availability of accessible, non-stigmatizing, culturally acceptable, and quality mental health services through integration in other sectors. Integration for us is very key. And of course, we always work to cover both immediate and more long-term mental health and psychosocial support needs with the goal of sustainability, and mainly through building on and strengthening existing structures and local capacities. Next slide, please. And so while today I will be describing IMC's approach to integration of mental health into primary health care and mental health case management specifically, I wanted to provide a brief overview of IMC's MHPSS programs in urban settings and how they aim to meet the needs of refugees and displaced populations. So we talked a little bit about the issues. So I'm going to kind of go through one by one and kind of just tell you how our approach and our programs kind of address these issues. So we talked about access and availability of services. So in order to improve or address this issue, it is very important to participate or lead in assessment, mapping, to facilitate sharing of information and the design and implementation of programs, ensuring that we are filling gaps and complementing efforts of national agencies and global actors, of course. So assessment is very, very key. Coordination and information sharing efforts are also very, very key among various agencies. And IMC in the Middle East now currently co-chairs MHPSS working groups in Jordan, together co-chairing with WHO, and in Syria co-chairing with UNHCR, and is an active member of working groups in Lebanon and some informal working groups in Turkey. And of course, talking a little bit about quality as well, quality of services being provided. IMC, we train volunteers and healthcare workers in psychological first aid, ensuring that people are linked to their needed services, but also ensuring that the delivery of services by frontline workers is provided in a supportive and a non-harmful way. So you can see that we have all the programs that we have kind of try to address the different issues at different levels. And of course, we work in line with our global approach to mental health to improve access and care by integrating mental health into general health care, and by training and capacity building and setting up mental health case management teams. And this also works in order to address the issues of urban refugees having multiple needs and needing a comprehensive system of services to address these needs. And finally, also in line with community-based structures and ensuring that we're offering outlets and building social support networks and empowering affected populations. We have various youth-specific and children-specific activities that are embedded within the community and that are established through existing systems and through local partners and through engaging the community, the refugee community itself. And in line with integration as well, we also integrate early childhood development into nutrition and health programs. And on this point of integration, we are talking about mental health entry points. And I'll talk a little bit about this in the coming slides. Next slide, please. So distressing experiences and fragmented or insufficient services, let's say, can lead to unaddressed mental health, psychosocial, and protection issues. And this impacts the welfare and functioning of individuals and families. So why MHPSS case management? Well, we're usually working with populations who have either faced past stressful experiences such as violence and loss, who often have to adapt to the challenges of new environments where access to basic needs is often very difficult, and who have multiple and complex needs. So these populations, these people, they require a comprehensive mental health case management approach, and that identifies their needs that supports them and protects them, and also empowers them to take control and ownership of their own care. Next slide, please. So before you, what you see is our case management team structure. So I kind of wanted to give you an idea of what case management looks like and what is the composition of our team. So you'll see that case managers at that lower part of the pyramid. So case managers who are usually either social workers, trained nurses, or in some cases there are actually psychologists who are not clinical psychologists and don't do the regular therapeutic type of interventions. They are usually our case managers, and they work as part of the primary healthcare system. And they're usually working in community-based centers or health centers, as I mentioned, and linked to trained primary healthcare providers. And of course, linked to community outreach workers, because outreach workers are key in case management and in linking people to services. And of course, you'll see that there's the psychologist and the psychiatrist. So in a sense, we built a team, and it is very important to note that the whole team is made up of national staff. I think the assumption is that we bring in these expats and that they provide services directly to refugees or to the vulnerable population. On the contrary, what IMC tries to do is that we come in, yes, we come in with expats, but we come in, adapt materials, adapt our training package to the training needs of the local population. We take on volunteers, we take on non-specialized staff in various cases, and we build their capacity to be able to become case managers and be able to serve their population, empower them. And of course, and depending on the country and the context, we also have specialized services. Because of course, when we identify people, we need to have specialized services to refer to. And often we also have expats who are building the capacity of national psychologists and psychiatrists to be able to provide that specialized support. Next slide, please. So in this slide, I wanted to kind of show you the referral pathways that are established both within the team and outside the team. And I think you'll notice in bright red that not all cases require specialized support. And this is really a huge misconception, is that because we have a psychiatrist on our team or psychologist, that everyone that comes or is managed by our case management team requires that specialized support. This is not true. Most of our cases can actually be managed at the lower level and can be managed by the case manager directly. The case manager opens and closes the case. This is the flow of things. So no matter who from the team is also seeing that case, the case manager is the one who takes ownership of it. And of course, they are linked to, so there's a two-way referral between the case manager and the trained primary health care provider and community outreach workers. And community outreach workers here are very, very key. So in our case, usually these outreach workers are community health workers, and they are, people from the refugee community. Sometimes, most often they are women, sometimes we have men in some countries. And what they do is they go to the home level and they provide health messages. But these people are also trained in identification of mental health issues or GBV issues, and then are able to identify and refer to the case manager, but also follow up. So the follow-up is very important. And one might ask, oh, but you're training people, what if they're not, what if they shouldn't, be providing any mental health support, etc. And the idea is we're not training them to be mental health professionals. We are training them to identify that something is wrong and accordingly refer to the case manager for support. And the case manager, you'll see there's a two-way referral between the mental health entry point and the case manager, because the case manager essentially will either receive cases from community-based psychosocial support services, other sectors like health or nutrition or water and sanitation, and of course from the PHC directly, either through walk-ins or outreach. But at the same time, the case manager is in a position to link people to services. So that's why there is that two-way referral. So the case manager, depending on the needs identified, will also refer to these different services. And then talking a little bit about the internal referral between case managers, psychologists, and national psychiatrists, there is that upward referral based on need, of course, but there's also a downward referral. So anyone who is seen by the psychologist or psychiatrist will essentially also be seen by the case manager from start to finish. So depending on the need for a specialized care plan or a basic care plan, the case management team members' roles are defined. So some cases are followed up by the case manager alone, and some are followed up by the team. And as Nancy mentioned, similar to that approach, we have weekly discussions by the team members, ongoing training and supervision and technical support provided to that team. Next slide, please. So I wanted to talk a little bit about Turkey. Now in Turkey, there are over 750,000 registered Syrian refugees, and only 200,000 of those are actually in camps. The rest are in urban areas. Now, there are challenges in providing MHPSS services to Syrians in Turkey. Mainly, there's the Arabic-Turkish translation is often not available or of very poor quality for urban refugees visiting mental health providers. In Turkey, and in Syria for that matter, there may be programming for community-based services and lower-level mental health case management services, but there is insufficient capacity building and support for the provision of more specialized services, including psychological and psychiatric services. And due to gaps in pre-existing mental health infrastructure, the referral pathway for displaced Syrians is actually often insufficient in Turkey. And of course, needless to say, you know, the government, and there's usually a lack of authorization for INGOs to provide services in certain areas. So there's that limitation as well. Next slide, please. So I wanted to share this short story from Turkey. S is a 42-year-old female who was forced to witness the massacre of her 4 daughters and husband in Homs. S is currently being provided support by our case management team in Reyhanli. And the way that the PSW was identified, we talked about mental health entry points. So in fact, S was first seen by one of our primary health care providers, and who then identified that there was an issue and referred the case to one of our case managers in Reyhanli. And of course, person S came in presenting with symptoms of, you know, feelings of hopelessness and worthlessness. And immediately, the case manager realized that this person required some specialized mental health support. So a referral was made to our national psychiatrist for an evaluation and treatment recommendations. So what was the support that was provided to her? Of course, after ensuring that S received basic services through referral to IMC and non-IMC agencies, the psychosocial worker also provided ongoing psychosocial support and follow-up to the client based on a mental health care plan that included set goals together with the client. So usually what we do is we develop a care plan, but we don't set goals for the client, we set goals with the client. And yes, of course, you know, one would say, oh, you know, this person has been diagnosed with PTSD and major depression, so the focus will be on that. So yes, definitely the focus should be on bringing this person back to normal daily functioning, but at the same time, we let the client prioritize their own needs. And one of the client's goals that she set for herself was to find a meaningful activity that would generate income. And accordingly, the PSW went out and ensured that her social needs and her specific goals that she prioritized for herself were met. And accordingly, now the PSW is, you know, is supporting, providing ongoing support to her. She is now working in a handicraft production and is generating some income. So this is just to show you the different levels of care and needs and the multiple and complex needs of the different cases that we see. And even if they require specialized support, often we need to meet the lower level of needs in order to impact their overall care and recovery. Next slide, please. So I wanted to talk to you a little bit about Jordan as well. So in Jordan, we have almost 600,000 registered refugees, 800 expected by end of this year. And approximately 80% of the refugees are actually still residing within, in urban areas. But in Jordan, I wanted to mention Jordan specifically because IMC is currently, kind of putting into place some innovative activities and initiatives in order to meet the needs of the vulnerable refugee populations in urban settings. Of course, as I mentioned before, we are working in line with WHO recommendations to integrate mental health into primary health care. But what we are now doing is piloting an innovative MHGAP e-learning program, which uses an internet platform and self-study modules in addition to face-to-face workshops as well. But what this will do is basically it is a more sustainable and consistent way of training Jordanian health practitioners, working towards more national capacity, improving national capacity to respond to MHPSS needs. This will allow coverage and reaching different healthcare providers in different areas. Jordan is huge, and kind of reaching them through this e-learning platform. Next slide, please. I also wanted to touch on Lebanon. So in Lebanon, IMC has informed a 3-year mental health strategy. And now Lebanon is working with the Ministry of Health and WHO to implement this strategy and roll out a countrywide training for Ministry of Health primary health care providers in MHGAP. And this includes a nationwide training of trainers. So in informing the strategy, IMC is now putting in the financial and technical resources in order to support the national rollout of MHGAP training. And we are also working with the Ministry of Social Affairs to expand MHPSS case management services linked to mental health PhD integration. So I know I'm running out of time, so I'm moving a little quickly right now. But just kind of ending with some takeaway messages. So it's very important to make MHPSS services and activities available to refugees as well as vulnerable host populations, because even in contexts where integration of refugee community is not considered a durable solution, the process of including both groups in assistance related to activities can produce notable and immediate improvements in the mental health and well-being of the refugee population. Second, we need to ensure that people can access various different services, including MHPSS, of course, through a case management approach. And this includes mapping of services available in urban settings, because this can actually be confusing to navigate, more so than in camp settings. Connecting and advocating with service providers so urban refugees can access services. This is also not needed in camp settings, since services are there for refugees only. Assessing multiple needs, connecting clients to needed services, and ensuring that there is follow-up to make sure that these needs are met. And supporting people through outreach support, because outreach efforts, they must complement organized activities. And the process of identification and referral to MHPSS and other services must be included in all programming. And of course, we need to coordinate with other agencies and service providers to establish clear and functioning referral pathways. We need to create access points for mental health services, because people will typically not come directly to receive mental health support. We need to establish these service points, mental health service points, access points through different sectors and different activities. We need to establish joint activities which include refugee and host populations, because this can help break down tensions with host communities and help with social networks. And finally, we need to reinforce social networks and social support, because it's easier, and this is, notably this is easier to do in camps where people are all refugees, but in urban settings, people can be very isolated. So this is very, very important. Next slide, please. And finally, I just wanted to end with these resources. We have the ISC strategy, meeting humanitarian challenges in urban areas, and an article also that was written and published by our Jordan IMC team, and it's called Anticipating the Unexpected Urban Refugee Programming in Jordan. I can also provide this link through Peter at a later stage. Thank you so much, everyone. And I apologize for moving quickly towards the end.
Okay, thank you very much, Zainab, and thank you, Nancy, as well. I apologize to all of you that we have already talked for an hour, but we have some more time to open the floor to you, and that's exactly what we're going to do now. So There's my slide. Yes. And I would like to open the floor for questions now. That is seems a bit difficult. Below the list of the names, you see a short, you see an icon with a raise hand. If you push that button, we will know that you want to ask a question, and we will be able to unmute you.
Yes, Peter, that's correct. So please use the hand icon if you have a question. And I already see Helen and Erin. I guess Helen was first. So Helen, now you're unmuted. Please.
Great, thank you very much. My name is Helen Martin. I'm the Regional Child Protection Coordinator for Reference Point. Thank you I'm sorry that I came in so late. I must have got mixed up with the times, but I found, Zainab, I found your presentation very interesting, the fact that I thought of it. And I was wondering, you were speaking very much about a case management model, but I was wondering if you had any kind of program for community development. So say you gave the example of a 42-year-old Syrian woman who wanted to go out to work, but what if she wanted to go out to work in order to get money because her daughter was not going to school because the boys were being prioritized for schooling over the girls, and perhaps helping families, communities to perhaps change their beliefs around what the around certain issues in order to assist people's mental health and over the longer term. And I was wondering if there was any community development over in order to aid mental health issues.
Thank you very much. This was Helen Martin, I think, from Nairobi. Helen, yes. To whom is your question addressed? To Zainab or to Nancy?
It was Zainab.
Okay, Zainab, can you answer on the question about the relation of the MHPSS work with community development work in urban contexts?
Yes, thank you, Helen. And from what I understand, definitely there, from your question, is that yes, definitely there are complications in terms of communities and accepting services and how they are provided, and especially when it comes to providing support to women and creating job opportunities for them or linking them to job opportunities. A lot of our work is around psychoeducation and bringing awareness to mental health issues and trying as much as possible to establish these types of education and awareness sessions within centers and clinics with the families. So when we are often working with individuals, we don't work with them on their own. With the consent of the case of the client, we usually bring in the family and try to work with them so that they are supportive of the care plan that is set with the client. But at the same time, we're also doing more wider scale awareness raising and psychoeducation for the wider community, and trying to, as much as possible, target influential people, people whose voices are heard as part of the community, and ensuring that they are speaking our language and they are supporting what we do and supporting, the systems that we have in place to meet the needs of the refugee population.
Okay, great. Thank you very much.
Okay, I see that Erin Kenny has a question as well.
Thanks, Nancy and Zainab. This is a really great presentation, and I appreciate your time. I'm Erin Kenny. I'm with UNHCR as their gender-based violence specialist, focused on humanitarian context. I actually have several questions, some of which I'll just follow up directly with you, Peter, to kind of direct as appropriate, but two hopefully not too challenging questions. Nancy, first to you. I think I've heard a lot about your program over the years, and it sounds really fantastic. And I think, I know you've done a ton of work in different types of contexts. I'm just curious what your impression is of the scalability of this project. It seems quite resource intensive, and so I'm just wondering kind of what the opportunities are for replication in other contexts. And then a question for both Zainab and Nancy on also just a little bit on the opportunities. I know that there are a lot of challenges to working in urban contexts, but it seems that there may also be opportunities. And I guess what I mean by that, or just kind of my impression, is there are opportunities around literacy and education levels of the host population, potentially also of the types of refugees that end up in urban contexts. And then also, as Zainab mentioned, an intervention involving an e-learning, the opportunities of actually a regular internet access. So I'm just wondering if you could talk to that as well.
Nancy, are you with us?
I am. Okay. I thought Peter was going to introduce it. No problem. Is that replication, Erin? Well, that's a very hard question. There are many people who've come to visit us over the years, and there are efforts to do different kinds of replications in many different countries. And so, yes, I think that programs can be replicated, but nothing's exact because, of course, it has to be different depending on context. Yes, we work very hard here, but you have refugees all over the world who are committed to their own communities. And I think with proper training and supervision that, yes, you can find ways to build a team that can do similar to what we do here. Like I said in the beginning, you can do it in Cairo. Sometimes I believe you can do it anywhere. So I do think that's possible. And I'll leave the second question to you, I think.
Okay, yeah, thank you so much, Erin, for this question. And just to touch a little bit on replication as well, yes, we definitely realize that it is hard to replicate, but from IMC's perspective, we are currently doing, we have a research project in Jordan to measure the effectiveness of our case management. And just to note that case management for us initially started in Jordan, and we were able to replicate the concept in the different, so now we have case management in Jordan, Lebanon, Turkey, Syria, and other countries as well. And it all started in Jordan. So it is a concept that can be replicated, but definitely not replicated by itself. I mean, we have to take into account that this needs to be adapted to the context, the human resources available. For example, in Turkey and in Syria, we don't have a psychologist. We don't have psychologists providing therapeutic interventions because those human resources are not available. So replication is possible if we think about, adaptation to the resources that we have in each country. And then you asked two other questions, one on literacy and education. That is definitely an issue. In Lebanon, we do have literacy programs. So often what we do is we link people to these types of services when they are not available by us directly. So it's, yes, we have our case management teams, but we don't provide everything. But in Lebanon, for example, we do provide that. So we do link people to literacy programs and ensure that people are there. And of course, we are not an education agency, but we do, for example, work with agencies that are integrating children into schools, et cetera, et cetera. I'm not sure if that answers your question, but that is my attempt to answer it. And with regards to e-learning, yes, absolutely, internet access is a huge problem. And actually, I can't answer those questions right now, but I can say that because e-learning now, what we're doing, it is a pilot. And definitely in the Middle East, internet access is definitely more available than, it is in African countries, for example. So the possibility of it working is definitely higher. But we are currently piloting this with a group of doctors from the Ministry of Health within Jordan. And we will hopefully be producing, some findings around how to kind of make it work. And as I mentioned before, it is an e-learning platform, but it is coupled with some face-to-face interaction because that is, of course, very key in, ensuring that people have the knowledge, but also they have the skills to implement and manage mental health cases.
Okay, thank you. But I would like to go back to the question of Erin, because what I understand from what she is chatting, she actually asked about opportunities that are provided by the urban context. Erin, can you add a little bit on that, because it seems you had a specific point here.
Yeah, no, I was just curious. I mean, we've heard so much about the challenges, right, and their events, but I also would anticipate that there are some positives to working in an urban context, or some potential positives if we know how to maximize them. And I know it's a bit of a leading question, but I truly don't have the answer to this. I'm just interested in your expertise.
Yes.
I can respond to that if you'd like. I mean, I think there are some opportunities. I mean, you know, you take folks from unstable, often rural areas where there's been no availability of education for kids, and part of the reason, in addition to being a refugee, but part of the reason they chose to come to the urban context is with the hope that they're going to get education for their children. I mean, so that's absolutely, and for some kids, if they come, depending where they come from, this is the first chance they've had to go to school. The problem in a place like Egypt is that there's just not enough places in school for all the kids, and so then you end up also with disappointment, where people have come here believing that this is the opportunity, and now they can't access it, or they can't access enough of it, or it's not very good. So, yeah, you know, yes, certainly, you know, that there are some opportunities that come with the urban context. No question at all. That's why people keep coming here. Opportunities for employment for some people. You know, that even though there's limited opportunity, you know, for some people they're coming from, again, very, you know, places where they can't get any kind of opportunity, and here they at least can be a domestic worker. They can work in a factory. It's better than nothing. So, yeah, and the urban context does have some opportunity.
Thank you very much, Nancy. I would like to go on to the next question by Marcio Galeato. Can you...
Marcio, you're unmuted. Please go ahead with your question.
Hello, everyone. My name is Marcio. I'm speaking from Brazil. I'm a psychologist, and I was working the last 2 years with IOM as a psychosocial program manager in Libya. So basically, my question is, it's just incredible to see the three of you together, and it's incredible to see the programming and the activities that you are all running all over the world, which is the highest standards I have seen in the field. But my question now is a little bit more moving to the political side of the program implementation. My question is, how do you see the funding system for MHPSS programming influencing the activities and also the relationship between the organizations? You know? How do you see the trends and possibly the gaps and the implication in the funding system and also the relationship with other organizations in implementing in the field such activities? You know? Because often in the field, the reality is not the same as we speak as a group. Does that make sense? Hello?
Okay. Well, I can say a little bit about it and then go on to Nancy and Zainab. I think here about funding, MHPSS has a problem, namely the fact that MHPSS is often not earmarked. It's not a sector, but it is an intersectorial activity, and it must be, which means that it's often difficult to get dedicated funds because they are split up for specific activities. So that is a basic challenge that we have and that we need to take into consideration when we are advocating. The second point I want to make is about interagency coordination, particularly in the larger emergencies, such as in Jordan and Lebanon now. We see that there is a paramount importance of the MHPSS coordination groups, and perhaps Zainab or Nancy could say something on this as well.
Zainab, yeah, I definitely, hello? Oh, sorry.
Nancy, do you want to say something on this point? Okay, Zainab, perhaps?
Now you turned me off. Now you turned me on. All right, so funding. You know, Of course the funding is limited, and limited funding, it's not just mental health funding that we have to worry about, is that the less funding that's available for the basic needs of people affects their well-being. So it's not just the funding around mental health, and that so the situation here in Egypt, as the funding has come down for basic needs, then we have more problems. You know, and so the people have more problems. We have more to deal with. But my attitude about funding is that, you know, you get funded when people can see your value. And we've worked hard here to have the UN and the NGOs and organizations and communities see the value of the psychosocial worker. That helps a lot. If people see the value, then they fight for funds for you. So I think that's an important, a very important point. Coordination, you know, when before the Syrians got here, we had 50,000 refugees. It was a nice small place. It was a relief after being in big operations for the last 20 years. As the Syrians got here, there's more partners. Coordination gets harder the more people that are here, and more competition there seems to be for resources or whatever. But the bottom line in all of this is the coordination is essential. You can't do anything unless you have a good partner.
Okay. Perhaps Zainab wants to react briefly on this, and after that I will continue to the next question.
Yeah, so very briefly on interagency coordination, Marcio, I think you mentioned something that's very key in terms of the complications that are associated with agencies coordinating with one another. Yes, it seems very easy and easy when we talk about it, but, you know, just kind of giving some very brief examples. In Jordan, definitely, I think we have one of the, you know, most functioning, I should say, interagency working groups led by IMC and WHO. But the number of agencies is huge, and it's very hard to keep track of who's doing what. Despite, of course, efforts to do 4Ws mapping on an annual basis, and sometimes even more often than that. In Syria, you know, we are having definitely security issues. We have a working group, a technical working group that is, you know, co-chaired by IMC and UNHCR as well. But there's definitely a huge problem in trying to get national partners on the table to coordinate with us, mainly because of the security issues, mainly because national agencies are, in most cases, not even allowed to work. So that in itself is a huge complication. In Lebanon, we initially had a working group in one part of the country in the north, that was led by IMC and UNHCR. That kind of fell through the cracks. And now we're trying as much as possible to advocate for a centralized interagency working group that will assist and facilitate the coordination. Like Peter mentioned, it is not a sector, so often it is forgotten. So now what we are trying to do is as much as possible is report on mental health within the different sectors and mainly health. And then finally, Turkey, where the number of actors is actually very limited because of, you know, INGOs are, very few INGOs are given permission by the government to work there. There is no formal coordination platform, but, you know, the agencies try to informally meet together to update one another, et cetera, and try to coordinate as much as possible.
Thank you very much, Zainab. I would like to go to Rabia, who has a question as well. Attila, can you unmute Rabia? And this will probably be the last question. After that, we're going to wrap up. Rabia, can you say where you're from and what is your question? Rabia, can you hear me? Hello, Rabia? Rabia, it doesn't seem to work. Perhaps you can chat your question so we can ask it on your behalf.
Yes, perhaps I would then unmute Peter if you agree. Jennifer, she also has a question until Rabia comes to us on the chat.
Hello? Hello. Hi, I'm Jennifer, the Community Service Officer at UNHCR in Armenia. I have a question from also my team, which is here with me. I would like to ask, how do you present mental health and psychosocial services to refugees who are visibly affected by either PTSD or have other mental concerns, but they are unwilling to face reality and say that they have these issues? So we have tried one way to bring psychologists or social worker counselors together and have group counseling, but we cannot have group counseling at all times. So when we really identify persons with PTSD, mental concerns, we really want to refer them to psychologists who are available. But these people are unwilling, and they are saying, like, I am not mentally sick, why are you referring me to such a doctor? So how do you actually present to some refugees from different maybe social backgrounds, how they perceive mental health and psychosocial services? How do you actually present these services to them? That was my question. Thank you.
Okay, thank you, Jennifer. Zainab or Nancy, perhaps, would you like to say something?
I'm happy to say something. Jennifer, I think that for us, the reason that we use community-based workers is so we don't have to say, you need to go to a psychologist, you have a psychosocial and mental health problem. A community-based worker is able to go into someone's home and sit with them and have tea and chat and ask what's different today than it was before. They're able to sit with them and say, you know, what's making you happy? What's making you unhappy? What are some of the stresses for you? What would be better? What would be, I mean, they look at the past and the present and the future with them, and they're not talking about mental health. But they're able, in their own language and sitting in someone's home, to open up the door to talk and to share. If someone has bigger problems that might need a psychologist or a psychiatrist, then the relationship they have with a psychosocial worker is the relationship that would be used to help guide them there. But it's clear that presenting to people that they have these problems is never going to be the way to get them to attend. I think that we talk about, you know, problems of the mind, heart, and social relationships. We don't use words like mental health and psychosocial support with the client.
Thank you, Nancy. This is Peter again. I would like to strongly support what Nancy just said. I am a psychiatrist by training, and in the 13 years of doing humanitarian work, I have become much more humble than I was 13 years ago. And I think that the problem is not that refugees do not understand that they suffer from depression or post-traumatic stress disorder. I think the problem is that we as professionals do not understand what is really at stake for the refugees. And that is not to say that depression and PTSD are not valid in other contexts. I think people do suffer from it, but our solutions do not match with the problems. And what I've learned is that the most powerful interventions for people with depression and trauma are often only indirectly psychological. And the effective interventions sometimes do not even call a problem a depression or a PTSD, but they work with people and with the problems that they face directly. They can do that through group work, through groups where people share their problems, through vocational training, through creative therapies. There are many ways to do this, and it's not necessary to teach the refugees first what problem they have and then to treat it in our way. But I'd like to give the floor to Zainab and then actually to wrap up. Zainab, do you want to say something on this issue?
I mean, I definitely don't want to repeat what you and Nancy said, but definitely just emphasize that it's really definitely about building trust and rapport with people, and definitely using their language. You know, the way that we refer to mental health problems is not the way that they're going to describe it. They're going to describe being sad. They're going to be described as, you know, Peter mentioned, and as I mentioned in my presentation, is that they often bring to the table their own priorities. So we should not be prioritizing their issues. They should be prioritizing them, and we should be guiding them and helping them towards, you know, their care, and in our own way build that trust so that they can receive the care that is needed, be that specialized services or meeting or basic needs, etc. So I think it is our responsibility essentially to do that.
Thank you, Zainab. So this is Peter again, and I'm going to wrap up. I thoroughly liked the presentations and the discussions. I learned a lot. Some of the things that I think we should perhaps emphasize more when we talk about MHPSS in urban settings is that it's not just causing extra problems, which to some extent is also true. We have problems in finding refugees and in connecting to refugees. But I think we should also emphasize on the opportunities that the urban contexts provide for us. And I think urban situations do provide lots of opportunities that we do not have in camp-based settings, and we need to seize upon them. Now, with these solemn words, I would like to close the session. I would like to thank you all. I would like to remind you of the website mhpss.net. Is a network for mental health and psychosocial professionals. There is a group on urban setting MHPSS, and I would like you to join that group. You can also go to the website on UrbanRefugees.com that I mentioned in the beginning, and we will make sure that this webinar will be uploaded there so you can see it or share it with other people in a later stage. I want to thank you all very much, in particular the two presenters, Zainab and Nancy, and all the participants from all corners of the world. I'm really surprised. We see people from all continents here, and I'm really happy, and let's hope that we can have this session as a starting point to have a community of practice on urban refugee mental health and psychosocial support. Thank you very much. I will be available for your questions. My email address was mentioned in the beginning, ventevog@unhcr.org. Do not hesitate to write us. Thank you very much.
Thank you all. We are closing down the session. I'm muting everyone so we can say hi. This wasn't the best idea since there are great noise coming in, so we are just closing the session. Thanks everyone. Bye bye.